and teaches this one. So you're stuck with me tonight, but we are doing the introduction to Intraosseous, but also I want everyone to know that we are doing many other things, including answering all your questions. So it's going to be a hodgepodge. I've yet to see one of these webinars where intro is just new people or advanced is those who already have the unit. So we're just going to go with the flow and it's going to be great. I first want to recognize these guys, Chris and Jordan. You already met Chandler as well. Be sweet to her. She awards her CE. And just want to say, I've worked with these guys for a long time now, and they're truly committed to us as pediatric dentists and the children we serve. And I love these pictures of them dissecting chicken bone or dissecting chicken legs so that we can all work on our intraosseous injections, including Jordan in this picture eating his breakfast beside raw chicken bones. And I sent a text once saying real men eat breakfast beside raw chicken bones. So they're great. And I also just want to say what they say, they really mean. They don't just talk the talk, they walk the walk. And this is Chris with Dr. Pamela Clark in Houston, actually there helping her learn to use the units. And I mean, these guys are there to help and they will absolutely do it. I like to start with a mindful moment. Many of you know I'm almost done with my yoga certification. I feel like I've just been inching up on it a long time, but I saw this tea bag and I was like, well, isn't that something? And it's hanging off my new smile cup and it says, lift up others with your peaceful presence. And I think that really embodies why we're all here tonight. We want to be able to provide care that is kind, it's compassionate, it's peaceful, it's not traumatic, it's not scary to them. This is what it's all about. So why am I here? I do not make any money, not even one single penny off any unit that is sold, but I do love what I do very much. And I'm a nerd from the A to the Z in pediatric dentistry. And I love the children we serve and I love my colleagues. So that's why I'm here. And that's why I teach all over the world. And then of course, circling it back to our friends. And I showed this little friend at the last webinar. So this is a 3-year-old who weighs, you know, almost 100 pounds. Her BMI is too much for sedation, too much for care at the surgery center. And here we are, you know, we're kind of, our hands are tied, access to hospital care is a thing. And before dental high tech, we just knew with each progressive appointment, when we knew these children, they knew they were going to get an injection, I feel like behavior absolutely deteriorated. And now we have a compassionate way to chip away at care when we can't do sedation or let these children go completely to sleep. So this is what we're looking for, the happy kids. That's why we love what we do, the fun stuff. We just do the other stuff because we have to. I want to take just a moment in the world of pediatric dentistry and actually all dentistry and celebrate all the graduating residents. Yay, congratulations. And their educators, because they wouldn't be able to do it without you guys. And especially Dr. Patrick Ruck. I have some videos I'm going to show of him. I'm going to say a quick little extra thank you. We have a close family friend that was in Cincinnati and her child had a terrible trauma. And Patrick stayed late to see my friend last night, or my friend's child. So he's the guy, but he's also an amazing educator. And I'm going to show these videos. This is one of his residents. I didn't actually ask Patrick, but I'm assuming he said, read the manual and explain to me how you're going to use this and then use it on me, because all great educators, you know, sacrifice themselves. And so I'm just going to play this video, which I think is so funny. And she's like, well, you turn it on. And I love that, because I'm not even going to kid you how many times I almost got to the mouth without the unit being turned on. So it's good advice. And then here is her awesome attending. She's telling the D, faces out. And then she heads toward Patrick. And I love this. And you know, he seems pretty stoked about the thing. I mean, there might be a little wily in his eye. I don't know, but it's going to go in a numb. And I really love this video because it teaches us a lot of things. I don't know if this was a first year or second year resident, but a couple little tips to do when we're entering the papilla. This is such a good view. We want to make sure we actually enter the tissue prior to the base of the papilla, because we're going to slide in, and the goal is that the bevel is at the base at that point. And she did pretty well there. You can see the light indicator blinking. She's on blue for a bond, and she came out a little bit. You know, it's her faculty. She's probably super extra nervous, but she goes back in. She's inching a little bit toward the free gingival margin there, but still doing a great great job. And she's delivering this local anesthetic in this first step. That is, of course, the soft tissue blanching, which also captures the periosteum. So you see us blanching here. So I would recommend in that set. That tasted great. Patrick said, yum. And she now is coming in, and this is great view, because this is someone who hasn't used this very much, and you're going to see the needle kind of bend a little bit. She's doing perfect rotating in her hand. Very impressed with her technique. The fact that she's using pseudofulcrum to try to stabilize herself. But you see the needle kind of weebling and wobbling. That's okay, as long as you're not pushing too hard, and she's not. And you're going to see a little tiny bit of advancement. Now, sometimes it doesn't take much advancement. A lot of people text me questions regarding this very thing, like it went in a little bit, but then I sort of stopped. But you can see on her pressure indicator, only one light is blinking. So I'm confident she's not the PDL. I'm confident she's just not sticking into the periosteum. That would make more pressure within the unit. It's just, that's as far as it went in, and she's delivering this. I'm going to fast forward through this just a little bit more, and she's delivering, and she basically delivers an entire carpule. And I'm going to get to this end here so you can see how she comes out. So she's getting toward the end, and one thing, good job. One thing that I would recommend you do when you take your foot off the pedal, make sure you say to yourself, 1 Mississippi, 2 Mississippi, maybe 3 Mississippi, before you actually pull the needle out, so you don't get that drip, drip, drip in the mouth, and you can avoid that a bit. Now I'm going to show you, let's go to this. Now what she's doing is doing vitality test, and I'm going to make sure there's no noise right now.
Wow.
Do another control over there.
So this is the real true sacrifice right here. My teeth are so cold sensitive. Actually, I think Patrick's are too. When you'll see. So let's see. This is the next one.
All right, let's see.
I'm gonna do this one over here first.
Oh man, I'm sensitive.
Put your hand up here.
I know.
So evidently he was raising his hand. It just couldn't be seen in the videos, but she just kept the cotton on there. Of course. And I love the test of an awesome faculty when she's trying to get his attention to raise his hand. She reaches down and kind of like wiggles his ear a little bit. Such a great program, such a great educator. All right. There are many great educators across the world. So Dental High Tech Academy has been around for a very long time. These devices have been used overseas for well over a decade. We're just really behind here in the States, and we're finally catching up. But these guys, and I'm not sure there's a girl on this page. Yes, I see a Clarissa. They have been doing what we are now doing for many years and are great resources and have mentored us as well. I love that Anne made us our own little special things to represent us in the United States. Speaking of Anne, so we have several excellent KOLs through New Smile Tech, and all these people are great resources. I know most of you know all of these people, and also want to let you know that Anne's next webinar is July 10th, so make sure you're there to see that and get all the great advice. And many of you may have seen Dr. Matt Lucero's Tuesday tip, and it was great. So keep up the good work, team, and feel free to reach out to all those guys. All right. So what do I do when I get it? All right. So this is where it gets real. You paid for this thing. It's sitting in your office. Hopefully it hasn't been sitting in the box for a month because you're a little bit worried. I mean, it's safe to be a little bit worried when you work with small children. But go ahead and take it out of the box and start with reading the manuals, cover to cover, and then make sure they don't get thrown away. Maybe put them in an extra special place, but start there. The second thing you want to do, this is priceless. Go to newsmile.com, products, New Smile Tech, and you can go to the SOAN or the Sleeper one, scroll down, and there's this onboarding button that sends you through a really great training program. Before this was developed, I had used these devices for several months, and I still learned something, and I haven't even finished going through it in full disclosure, but the parts I have gone through, I learned, such as when you stick your high-tech holder make sure you don't load it for 24 hours. And that was one of the things that people asked me questions about, like, why does my thing fall off? And it's because they didn't watch this and they stuck it and they instantly put weight in it. We don't have ours mounted because we have a magnificent left-handed doctor in our office, so we got to easily go side to side. Also, come see us. We have visitors literally every week in our practice to watch dental high tech in either location, 5 days a week, being used just all day long. So come see us in Raleigh. If you scan this, has all my contact information. Texting me is a very good way to get a hold of me because I get so many emails. I get a bit buried sometimes, but come see us there. And I wanted to address something really funny. So the last time I did a webinar, someone said, I love that you use this, but I know you're the zirconia girl and you have this bougie practice in Raleigh, so you're not really doing a lot of extractions and so forth and so on. And I was like, wait, what? Pump the brakes a second. We do have quite an eclectic practice. It's a dichotomy between, yes, many of our referrals are fee for service, full mouth zirconia, so forth, but we also have a practice that's 30% those with special healthcare needs, which really lends itself toward Medicaid. And we see a lot of really sick kids and we see a lot of children with significant disease. So we use this device for everything, not just zirconia or just composites. We use it for everything. And this is one of my favorite little people. Other questions. So tonight's lecture is just going to be a series of questions and questions and questions because I want to make sure I answer everyone's question. And I know if someone texts me a question, other people are probably thinking it. So I would like to do intraosseous delivery, but I'm not sure this is the best system. What do you think the best delivery is? So full disclosure, I have not used every single product on this slide, but I have used many of them. The thing to know is that most of these actually aren't intraosseous. They're actually periodontal ligament devices, such as single tooth anesthesia, the wand. And then the other thing to know is that of all these, some of these are intraosseous devices, but dental high tech is the only device that is intraosseous, that has a pen grip, and also has a special needle. So if you want to have all of the toys in your toolbox to make this a better process for you and your patients, that's what you want to use. So we have to rethink our strategy. We were trained, unless you are one of Patrick's residents or one of Paul's residents, most of us were trained to do infiltrations and give blocks. And so we're trained to chase these nerves. And oftentimes we're chasing a nerve that is actually really far from the target, when truly all we're trying to do is anesthetize the tooth right as the nerve enters the apex or apices of the teeth. That's all we really want to, that's all we want to get. So we're not aiming for the nerve as much as we want to fill where the apices are sitting with a solution that captures the nerves, the innervation to the tooth. And it's just a different school of thought. So what we're basically going to do here is come in and we're going to blanch the tissue at the base of the papilla. I like a 4 to 5 millimeter blanching radius. And then we're going to come out. We're going to come in at approximately a 45-degree angle. We're going to talk about variations in a minute. We're going to pop through that periosteum and we're going to deliver this solution to basically fill this bathtub that the apices of the teeth are sitting in. And by doing that, we capture the innervation and anesthetize the teeth that we're trying to anesthetize without anesthetizing non-necessary peripheral tissues or frankly, any other teeth. We don't need a central incisor anesthetized when we're working on 230. And that's how this works. All right, let's go on. This is basically, a mock-up of what a pediatric setup in the primary dentition, where we see the developing tooth buds. A lot of people are very concerned about what's going to happen with the developing tooth buds. And the important thing to know is we should never be anesthetizing a child without a radiograph anyway. And we're not putting intraosseous anesthesia in a furcation or aiming at the apices of a single rooted tooth. We're aiming between the teeth. And even if we see, which we do so frequently see, ectopic premolar buds developing, they are, 99.9% of the time, they're mesially or they're distally ectopic. They're not superiorly ectopic. It's just not super common to see that happen. Very, very rare. So we're just aiming for the bone again, not aiming toward the apices. And I wanted to address a question that I got recently in the last few weeks. And it was, do you ever see pulpal necrosis with intraosseous anesthesia? And it's a great question. And the answer is absolutely not. Absolutely not. And in fact, it's so much safer than when we're going to heroics, when say we can't get a hypomineralized molar anesthetized, we start trying to do these PDLs and do these other things, especially if it's a second primary molar, which sometimes we see that. There's a study that goes back, it's an 80 study, but basically it's a pretty convincing, statistically convincing study. When it looked at, they took 16 monkeys and they used one side of their mouth as a control, and they used the other side of their mouth as the study, and they gave PDLs on these monkeys. And what they found is 15 of the permanent teeth actually had enamel, either hypoplasia, hypomineralization, or both. 15 of the 16 monkeys, where the contralateral control side of the monkeys had none. So it makes you really think twice about delivering, for me, in a primary tooth, delivering a periodontal ligament injection. And I just don't like them very much. I tried them for a while. I don't like them very much because I find oftentimes the children are a little pressure sensitive, a little percussion sensitive. The periodontal ligament is very sensitive, where the trabeculated aspect of the bone, where we're delivering this local anesthesia, is not. And that's why this is the most pain-free injection we can possibly give. So the way this works when we do an infiltration, we're coming in and we're going through the tissue, and ultimately our solution makes its way through the Volkmann and Haversian canals, and it gets to the target we're heading at. That's basically what we're doing. When we start intraosseous, we skip the middleman and we just go directly into those highways for local anesthetic, as I would like to think of them. And we're taking out the middleman, which means we're taking out the peripheral numbness. Now, will the soft tissue that is attached to the periosteum get anesthetized? Absolutely, because ultimately our anesthetic solution will diffuse. On the maxilla, it's magical. We all know maxillary bone is magical. They're easier to elevate. Teeth are easier to elevate when we're removing them. We have more success with infiltrations on the maxilla. For all those reasons, diffusion is more robust. We generally get 2 to 3 teeth forward and 2 backward, whereas on the mandible, we normally just get 1 distal and a few forward. And Dr. Prin likes to say the wind blows mesially, and it's a good way to think about this always. So if we have our little friend here and we want to anesthetize the right posterior mandible, giving an injection here is going to be a good way to capture 3 teeth. It's important to remember, so many people were in this mindset, yes, we give less anesthetic, yes, we give less anesthetic using intraosseous, but you need to size up your little friends when you look at them. This might be a 5-year-old, but this 5-year-old might be a robust little friend who has this brachycephalic mandible that's this big space to fill, and a half a carpule may not capture these 3 teeth. You might, on a larger kid, need to give more, like 3/4 or a full carpule. So keep that in mind. Just don't say, oh, it's a half in each quadrant. And in fact, if you're going to fudge on giving more. And of course, we don't exceed maximum dosage limits. My general rule is 40 pounds per carpule for articaine, and I stick to it. Now, one little caveat to that, because the very delicate sense system of the plunger, which will not let you overpressurize the bone, it will also not let you completely empty a carpule anesthetic. And frankly, I wish that conventional cartridges or syringes my entire life wouldn't let me do that. So I didn't do that last little bit of squeeze. That's so much wear and tear on my hands over the years. But you'll find you'll still have like a little tiny 7/8 of the carpule is gone. So keep that in mind when you're doing your calculations. The other thing is if you have drip, drip, drip that you let exit, or you took it out and it's still drip, drip, dripping, that counts towards your anesthetic. Remember, every little bit of anesthetic you lose, you lost that. That's not intraosseous, so it's not having the ability to provide this profound anesthesia that we're seeking. I think, as a general rule, pediatric dentists, including myself, we do the over blanch step too much. So we're actually depositing more in the blanching step than we realize. And then what happens is when we look at our cartridge, we're depositing less intraosseously than we realize. So be real cognizant. This is an image showing when you give a midline injection, you can expect that you would see up to 6 teeth worth of anesthesia. There are no right and lefts in intraosseous anesthesia. There are no midlines. It is simply just a casing holding the apices of the teeth, and we're filling that casing. Now, I would say when you look at this image, if you're expecting to get 6 teeth across the maxilla with your articaine and you want that much diffusion, I would plan for 1 to 200,000 epi. Absolutely every time. If you're just doing the D through G, which is pretty standard for us, you would be fine with the 1 to 100,000 epi. And one really beautiful thing about profound anesthesia in the intraosseous system is there's absolutely no way, when you know you gave 1 injection in the middle, there's no way you would see this blanching in this from the vasoconstriction unless you had diffusion of your local anesthetic that really crossed through the Haversian and Volkmann canals and transversed its way all the way across and actually came out through the periosteum and vasoconstricted that soft tissue. That is a sign of some really good anesthesia. Really. Now, do you have to see this every single time? No. Sometimes the blanching is so very faint. You don't even realize it's so very faint. For me, I like to see blanching on the contralateral side because that tells me I'm injecting on the facial or the buccal, and it's telling me it's diffusing all the way through the width of the alveolus. So I really like to see that, but blanching is your friend. We'll talk about that a little more. And this is the mandible. Again, if I'm going for this many teeth, I'm using 1 to 200,000 every time. If I'm just asking for a couple teeth, 1 to 100,000. The other thing, if I'm going for all of these teeth, and this is a normal size, let's say it's not a teeny, some of those little children, their little wrists are like little birdies and they have little tiny everything. If that's the situation, you probably could get away with a half a carpule, 3/4 a carpule. But if this is a child that has any amount of width to their alveolus and they are fairly big bone kids, and you know what I'm talking about, in this situation, if that was my goal, I would probably use a full carpule, which we really know is about 7/8. So again, the injections, we're expecting to see 2 forward, 2 backward, sometimes 3 forward, mesial on the maxilla, only 1 distal on the mandible, and 2 to 3 forward. And then the midline injections, if you use enough anesthetic and switch to 1 to 200,000, you will appreciate more diffusion. And that is something I've really learned in the course of my time using these devices that is so imperative. And actually, I wish I could go back. I know so much more now than I did in October when I first started teaching. It's just like the skies open up and you're like, oh, I get all this. And it's just so easy. I wish New Smile would go back and delete the earlier ones. Okay, just know this is what's important. I've gotten to the point where I pretty much just use 1 to 200,000 now, because with an intraosseous injection, and we'll get into the epi bit in just a little bit, I'm not worried about systemic effects of my local anesthetic at all. I'm also obviously not worried about an intravascular lesion. There's so many things we're not worried about, and I can work so much quicker because I'm not walking away. I'm staying with this child start to finish. I'm not worried about my anesthetic wearing off. So there's really, the value of epinephrine is decreasing to me every day, where the value of diffusion is increasing to me every day. And it's been basically just swinging the needle from one side to the other from everything I was trained, which is basically, you're going to hell if you don't use 1 to 100,000 epi in children to keep them safe because of the systemic effects, potential systemic effects of the back then lidocaine. Okay, so the special needle design. Even I tell people every time, even if you switch to the Epitech needle, kept your Yale syringes, you would do a great service to the friends you serve, because these needles are like scalpels. They pass right through the tissue. Most children don't feel them. One of our colleagues in Florida said, They don't feel them if you use nitrous. I feel like they might feel a little something if you're not using nitrous. So one thing to pay attention to, and there's several more examples of this, but the angle that you come in, you basically must have the bevel lined up, and it'll always be right if that D is pointing out, and making sure you're 20 degrees off the side of the alveolus, and you want to deposit your solution with the bevel down so you don't have to go deep, which will capture anesthesia for the periosteum. The most sensitive place of an injection is actually not the soft tissue, it's poking through the periosteum. And that's why when we are doing infiltrations, say in the maxillary interior, which, oh my gosh, they hurt. I'm so glad I don't do those in my life anymore. And the kid is bobbing and weaving or doing something, and they do this and you touch the bone, that really hurts. There's a lot of innervation on that surface. So again, we're making sure we're not going too deep, that we actually accidentally touch the periosteum. We are just barely sliding in the soft tissue, just doing those few drops of blanching and letting the magic take place. And I want to just address another question. I get this question probably 10 times every day of my life, and it's, do you have to retract and change your needle and change your carpule and change all these things every time? So for each quadrant, Dental High Tech recommends that you switch out your needle. And there's a very good reason for this. This increases your opportunity to give a painless injection. When you dull your needle, they're probably going to feel the blanching step. And I will say sometimes, especially with very, very small children, this is a very small child. This is a fresh 3-year-old, as I like to say. And I was doing work on basically the second and first primary molars in the upper and lower quadrants, and time was of the essence. And when I passed through my intraosseous anesthesia in the first quadrant, it didn't pop, it didn't do anything. It was like passing through butter, unnoticeable other than my needle disappearing. And so when I finished half a carpule there, I quickly came out and I just dropped into the other quadrant to be super fast, and it was fine. Now, if I meet any resistance at all, if I have to do any twisting, if I have to come out and go back in because I need to come at a different angle, if I have to do any of that, absolutely change your needle. You are just setting yourself up for failure in a bent needle if you have a dull needle trying to do an intraosseous injection. And most importantly, it will hurt your friend because the blanching step will not be pain-free. They will feel that penetration into the soft tissue, and we do not want that whatsoever. As far as, and let me show you another example. And this is just yesterday in our office. This is not the work from our office. This was a toothache friend that came to see us, had failed pulp crowns on these teeth. So in the situation of infected teeth, the standard is exactly as it is with a conventional syringe. We do not want to pass a needle through a space of infection, take it out, go to another area of the mouth and pass the needle through another, because we know that we have just passed that needle through an infection and bacteria, and we don't want to spread it. Even if there's an abscess on the other side, they might not be identical bugs. We don't want to double up on the bug load. So if you have sick teeth, yes, I would absolutely switch out the needle before I go to the other side. And this brings me to a really interesting little piece I want to throw in there. And I learned this just over the course of time. When you look at this little friend, you can see, okay, someone has taken out first primary molars, someone has attempted pulps and attempted crowns on this little friend. This friend has recently had a lot of work because the bone it's not completely filled in. Even if it was filled in, the fact that they had an extraction there means that the bone deposition is not as organized as it was if it would be healthy bone. So trying to get through intraosseous, get through the bone on non-organized or secondary healed bone is vastly, vastly more easy than bone that has never had any issue with it. It's well organized in its deposition. Getting through that periosteum is going to be much, much more challenging. So just keep that in mind. When you see it kind of modeled and kind of speckly, you're like, yeah, that's going to be easy. And when you see a very solid line of periosteum, you're like, that's going to be a little bit more of a challenge. And much like learning to do zirconia crowns very, very well, you have to start looking at radiographs in a little bit different light instead of looking for just caries and pathology and what is going on with teeth, you are going to pay so much more. And we're trained to look at bone levels and so forth and look for radiolucencies and all radiopacities. But now you're looking at where's the bone at? Where's the best place that I can give this injection? Not only that, is what is the thickness of that periosteum? How much effort am I going to need to get through that? And you start seeing things differently. And that's when the skies open up and you have this epiphany, like, I can get through anything because you know what to expect and how to approach it. So the 3 stages, again, are the mucosal or the periosteal anesthesia, followed by the bone penetration, and then ultimately the anesthetic delivery. And I want to just bring back to light, and this is very funny. I'm going to show you in just a minute. It's a picture of one of our hygienists, and I did not train her to do her first initial local anesthetic. Trained her to do it with these devices, trained her to do it with children, but she does the yay old school, hold it out with the mirror without having the circle of safety, closing on the child to make sure everything is right into place, because this is different hand holding, different stabilization of your little friends. You don't want to be dangling out with the mirror, retracting a cheek. You're not, 6 inches from where you're aiming with this long syringe. Everything is very up close and very safe this way. So the circle of safety is important. And I love this picture of my patient because she's already got it figured out to brush teeth. She has got the circle of safety locked down, ready to scrub that kangaroo's mouth. This is my practice partner's hand. And one thing I want to remind everyone, because this is so very, very important, especially when you're using a 9mm needle, everyone understands with conventional use of a syringe and a needle, you should never violate the less than 5mm of needle out of the soft tissue. That is a huge, huge liability if you violate that. Why? The child moves, you have a hub separation, and then it's gone because you're not in intraosseous tissue. And particularly with inferior alveolars, because the pterygomandibular space and the nature of the pterygomandibular muscles to retract that needle and pull it out of the way. And I won't get into the details, but anybody's heard me talk before, I've been expert witness on 2 hub separation cases, and it's just very scary. After all of that, if that's not enough to use intraosseous anesthesia, I don't know what to tell you. But when you do an intraosseous injection, 2mm, but even 1mm is perfectly fine. And what if the child moves and you had a hub separation? It is not going anywhere. It's just going to be sticking right up there, waiting for you to grab it with perhaps a 110, a Howell plier, or whatever instrument, or perhaps just your fingers, depending on how dense the bone was. It's not going to disappear out of sight. So you want to make sure you get that needle, ideally 2mm, 1mm is fine. But with that said, I find the older people get, if you get the pop through, and we're going to talk about this in more detail, and maybe you don't submerge to that 2mm, but you felt a definitive pop and you're into that space, you are delivering an intraosseous injection. You're just delivering not a conventional intraosseous injection. You're doing an intraseptal injection at that point. And why is that different? Because you're likely, where you're delivering it, only to capture 2 teeth in anesthesia, 1 mesial, 1 distal. In an ideal universe, you wouldn't want to consider doing that if you were using 1 to 100,000 epi. So I forgot to ask Patrick if his resident remembered to use 1 to 200,000, because delivering a whole carpule, this intraseptally in this position could potentially offer up an ischemic event with this high concentration of epinephrine. And some people will say, oh, you can get a little ulcer. I haven't seen that, but I definitely have had patients report, one of mine and a friend of mine, before we did the switch to 1 to 200,000, like they felt like a little pinch later on that day or something. And it was probably just a little bit of an ischemic event, and it resolved 24 to 48 hours. So again, the value of the 1 to 200,000, big deal. Topical anesthetic. If you're just one of these people and it makes you feel good, knock yourself out. A good friend and great colleague of ours in Turkey, he uses topical, and I asked him why. He's like, oh, it just makes me feel better. Well, if it makes you have the warm tinglies, well, do that. For me, I haven't used topical anesthetic since March of 2023. I just don't need it. And for so many children, they don't have a good response to this. They don't like the taste, they hypersalivate. Sometimes they GAG. We don't say that word out loud. So I have abandoned topical completely from my armamentarium. Back to the pop. Sometimes you feel the pop. It is very tactile, available to your senses. And sometimes you just don't. But it is rare that you don't actually feel the tug trying to exit the bone. So if you don't feel a pop, but your needle disappears and your angle is what it should be, which we'll talk about in a minute, then I am certain you are in the bone. If you feel a pop, great. It's kind of rewarding to feel that. And actually early on, it's actually a wee bit alarming because it's like, oh, I just felt that. But either way, the bone disappears. The needle disappears, it's going in the bone. So another question, doesn't the slow delivery slow you down? And this just kills pediatric dentists because we're trained to do this thing this way we do it. We sleepy, we walk out, we see our exams, we do the thing, we come back in, we get started. It's a complete change of our workflow process. But I will tell you, once you adapt and know, you sit your tail down, you sleepy your friend, you completely finish their treatment and you get up and you drive on. Your life will flow so much easier. Your friends will be so much happier because it doesn't hurt and they're in the chair so much less time. They're not just sitting there slowly getting numb and agitated and tired and frustrated. And I know all of us experience giving this beautiful injection, no tears, no problem. Conventionally, we go check a few recares, and by the time we come back, they're over it. They don't want to be there anymore. This is not going to happen with intraosseous anesthesia. And this is a schedule that's actually pretty typical of my practice partner and myself. We typically run 6 chairs, 2 ops, and 4 other things with room for emergencies built into that. And I have so much bonus time now. I see so many more children as what we call lucky days, where I see a recare and well, guess what? No, there's no one in my op chair because I finished them so fast. So we'll take care of that occlusal, or we'll get your sealants done today, or we'll do something like that. Just want to talk about the journey. So with all this said, and I was talking to Chris and Jordan Chandler before the webinar started, and I said, I have to remind myself now to discuss what it's like in the beginning, because it's really easy for me to forget now. Now it just seems so simple. It's almost like cheating. It's so easy that I just don't have tear. I mean, obviously the child that came in to the parking lot crying, you're probably going to have, it's hard to change that temperament around. But the child that's worried about an injection, like, you going to give me a shot? No, I'm not. I'm going to take your tooth temperature. And I say, lie like a rug. And then if you don't want to lie, sometimes I say this to him, like, let me check. I'm going to take your tooth temperature, then we'll figure it out. And then I do intraosseous anesthesia. I'm like, I'm not actually going to have to numb your tooth. I think it's fine just the way it is. And they don't have peripheral numbness. So they're like, oh, okay. And that's great. But you just don't jump in and do everybody like I do in my life now. Unless, of course, you're Patrick's resident. You just jump in and go for the Advil. Or you're at one of the workshops and you want to numb me, and just jump in. And I'm down with that. So early on, the first month, I only did the primary dentition. I made a commitment that once these devices showed up, and the first thing, we got one of each, because I wanted to know which one I liked better. And to make a long story short, there was quite the discrepancy in opinion amongst our 7 doctors. So we ended up with 3 of each between the 2 locations. But needless to say, I exclusively used these devices, but I only used them intraosseously for the primary dentition. And then the next month, I graduated up to the early mixed dentition. And when I say I exclusively used them, I just used them like a conventional syringe. If I was removing permanent molars, I used them to block the lower arch. I did everything I normally did with a conventional syringe. And then over the course of months, with a lot of love and mentorship from Dr. Alp and Dr. Prin especially, I kept growing and growing. And I like to say, I finally graduated in the summer to dabbling in the permanent dentition with Fuggle. And I think you can figure out what that means. A little bit of a struggle with a little something else on the front end of it. And then you get a little bit less. And then by January, I felt like I was ready to fly and everything was good. But ironically, I still had needle bends and I actually had my first hub separation. Why did I probably have my first hub separation? Because I was developing more confidence, like I can get this in here, I can get this in here. And I should have switched a needle at that point and tried with a fresh needle. So another word of advice, if you have multiple attempts, switch your needle. You'll be surprised how it can work so well. One of the greatest keys to crossing over to be able to use these devices for everyone, regardless of their age, is I abandoned the instruction manual would suggest for adults that you use the white tip, which is a 16 millimeter needle. And if you are just an amazing human, way more amazing than me, I'm quite certain, will you go for it? And I did have some successes. But when I finally learned the simple physics of controlling the force across 9 millimeters versus controlling the force in the long axis of the device and the needle across 16 millimeters, that made a big difference in these hands. So I completely switched at that point to the 9 millimeter, all I use. I haven't opened up, since January, I haven't opened up a white tip at all, not a bit. But I use always the 1 to 200,000 on the epinephrine because I am realizing I'm not doing a standard interosseous anymore with these big kids. I'm actually doing an intraseptal. And if I need to anesthetize more than a couple teeth, I will do an additional injection. And I will show you some of these in just a minute. And I love this saying. It's another thing I learned on a yoga workshop. It says more doors are open with kindness than force. And as you're passing that needle through after your blanching step, I want everyone to say to themselves, more doors are open with kindness than force. And think about this labyrinth. Think about the bone. The periosteum is this labyrinth, and you are navigating the needle through it gently, kindly. You're rotating it. You're letting it find its way through the little patterns, microscopic patterns in the bone, and be calm. Take a deep breath. When you get impatient and you push it, that's when you bend needles. So just relax. It's going to be okay. Just a quick tip. I hope I still have the accurate prices on. I should have checked this with the guys. People always text me, what do these cost? I'm like, I had to bring up my slideshow. I have no idea. But what I do know, people ask, I think I have the question listed someplace, like, how long did it take you to get your money back from these? Well, we have a very big practice in 2 locations. So honestly, a week with the opportunity to be able to see more friends, and not only because you're staying put and you're working through these procedures, but when your friend is not happy because they don't like the numb feeling and they're fussy and maybe they're not holding perfectly still, everything takes you longer. So when you have this happy friend chilling out, breathing their nitrous, watching their movie, they don't have a big fat lip that they don't like, and they don't have a fat tongue and a fat cheek, and they're just chilling out and you're getting done fast, that opens up so much more time in your practice day, more opportunities, especially with the summer months coming when we're all so busy. This is your time to condense those operative appointments, squeeze those patients in so they don't have to miss school. It's really important. There's a lot of stress on the little ones with missing school these days. So again, the options. Just because you have this device, it doesn't mean, when I say I have only exclusively used these since March, the using them exclusively for intraosseous has really been in 2024, January of 2024, but you can do an infraalveolar, you can do an infiltration, obviously you can do an intraosseous. The second picture, I type in intraosseous, an intraseptal. You can use them to do PDLs. I personally don't recommend those for primary teeth, but a lot of people enjoy doing that. You can do all of these things with the same device. So I like to say 16 months into, it's my dog Daisy. My husband and I are recent empty nesters, so this is our spoiled, rotten lab. But 0 use of conventional syringe, 0 inferior nerve blocks in the primary dentition, no infiltrations in the primary dentition. Haven't seen a chewed lip, cheek, tongue, none of it. No topical, no dominant right hand pain, which is a pretty big deal. We have very long hours in our office and we do a lot of work. I have profound improvement on my local anesthesia of hypomineralized 6-year molars, 90% plus less tears. or singing. We don't like using the word cry in our office. Efficiency and profitability. And this journey has made me really relearn what I probably learned as a dental student, the chemical structures of local anesthetic and the actual relationship to epinephrine and the selection of what we do for our patients. So overall, my practice life, my conventional days, I do have a lot of surgical days, but my conventional days in the office, yesterday was Tuesdays are my very long conventional days in the office, 10 hours of patient care. We do operative, we huddle at 6:30 in the morning. We do operative patients. I do, not all the doctors. I see operative patients because I've been practicing for 25 years. So I have a lot of older kids. I even have some college kids that can't come in the morning. I see operative patients until 5 p.m. when we finish our day. So it's complete. Like I said, it feels like cheating some days. So no more of this. This is mom's hand and this was sent from the pediatrician. That's just so disappointing to see that. Here's my fingers, and this is only after a month of use. If you've never seen a ganglion cyst from overuse, that's what this little guy is right here. I used to have 3 of them, and now they're even a little bit better since I started using the device. Unfortunately, the handpiece still contributes to that a little bit. You can see my dominant hand, I couldn't bend my finger because of the inflammation of that joint from doing the conventional syringe, especially on the palate. And we do a lot of surgical procedures in our practice, so there was a lot of that. So we all seen this picture of this type of little friend. That is the look of anxiety. In this day and age, to still be wearing a mask, she's worried about a shot and she's worried we're going to give her COVID still. So we don't want to lose the faith of our little friends. And you truly do, pun intended, have one shot to win them over. And one thing that I just want to help everyone wrap their head around is when someone is fearful, their perception of pain, well, everyone's perception is their reality. So when people say this is a pain-free injection, well, if someone detects pressure as pain, if that registers in their brain, they're going to say, oh, that hurt a little bit, but it's nothing like a conventional injection. Most people are completely oblivious, 90+%. But once you hurt someone, and then now they're fearful of you. So the next time they come in, it's going to hurt anymore because they're already going to be so tense and their brain is telling them something's going to hurt. It's very hard to talk them out of that. The neural pathway is set. Their anxiety is already on the ceiling. So just start the little kids are the easiest ones. So start every little kid out with not developing the fear of us. It's sad that that's the way it is being a dentist. So real quick device coverage. This is a Sleeper One. I stand by, it's still my favorite. I love that the light goes all the way around. I think it's easy for the kids to see. They think it's cool. I love it has a cord. I love for kids to see a cord because by all means, everything that has a cord is delightful in their world today. So how could that be something bad? Who's seen a shot with the cord on it? I think it's amazing. This one, and it's also a little bit lighter than the Soan. Of course, the only downside is it has a cord. I also like that it is kind of a point and shoot. You don't have a bunch of different settings that you need to change around or worry they got changed before you picked it up in your hand and do all these things. This is my favorite, but we do have 3 of each. I think the other doctors, at least a couple of them, profoundly prefer the Soan. And if you're entering the market and buying one and you run more than one operative chair, probably best to buy a Soan because it's easier to pick up and run with. And if we are seeing lucky day friends in our open bay where we're doing a quick extraction or ortho extractions, the parent comes in with, oh, and by the way, we were supposed to take the premolars out and they were there just for a recare. It's very easy to grab the foot pedal, grab the Soan and just go running with it and take care of it in the open bay versus being set up in the operative room. So this is what the foot pedal looks like for the Sleeper One, which is another reason why I like it. I like that the inner pedal is green. I wear loops in my peripheral vision. I can see this a little better without looking down on my feet. And we will go through what to do here, but basically the inner pedal, regardless of what color you're on, and the Sleeper One has 3, is drop by drop. This is singularly used for that first step, the initial mucosal anesthesia. There's 3 other colors, regardless of the device. Blue for bone, always, that's intraosseous. Pink is for intraligamental or palatal, and orange this is a must. You have to be in orange in this device to be able to aspirate So you must use this for the inferior alveolar nerve injection. Aspiration is also the plunger retraction. So if you tap it twice, you'll retract your plunger. If you press and hold, you'll get the retraction you're looking for. And will you accidentally do it a little bit too fast a couple times? Yes, and then you'll get the hang of it and it'll be very easy. You have to use at least 1/8 of a cartridge to get this aspiration, and it does work very, very well. There are options to change the speed. I recommend you just don't do this because in the orange setting, you already exceed the magical 1 milliliter per minute flow, which is what we strive to stay at. So I would just leave it as it is. Don't change them. The SOAN, it's the fanciest, newest, has all the bells and whistles, all the adjustments, all the things. You can see the pedal. The color of the inner pedal is a little bit different. There's only 2 colors here, but this, of course, is much more portable. My big thing about it, and of course, this picture, our hygienist kills me because she's doing a mirror retraction. And after I saw this picture, I'm like, no, no, no. She has nothing protect. This is a good example of no, don't do this. She has nothing she's stabilizing the child with right now. She's completely free flowing. Hands are not in contact with the child. That's not what we're looking for. Even though we're less worried about a hub separation in this situation, if anybody has ever had a child, which would basically be all of us, jerk away, if they do that and you don't have the child in the circle of safety, you could drag the needle across their face even and inject them. You could stick the needle through many things could happen. I don't recommend doing it this way. But needless to say, that's how she was trained. And I'm having a hard time breaking it, even though she's an amazing hygienist and a great person. So again, blue for bone, intraosseous, also intraseptal, which is a form of intraosseous, just a little bit different, intraligamental, palatal, and pink is the infiltration and infraalveolar nerve block. Again, on the SOAN, you absolutely have to be in pink to use the retraction or aspiration feature to make sure that you're not in a vessel. And you again have to have at least 1/8 of a cartridge gone to do this. Same principles apply. Inner pedal is solely for the initial mucosal anesthesia, and despite what color you're in, it'll be drop by drop. There's many little bells and whistles on the SOAN you can play with. The way we like to roll, I like to have sound because the kids think that's funny and they like it. I don't like the cartridge to have an automatic stop at, 1/8 and 1/2. I like it just to flow on drive. There is a cruise setting where you can tap it once and it just flows itself. The reason why I don't like the setting is because you have to tap it again to turn it off. And the other thing, because we have a sleeper 1, we're having 2 different devices used 2 different ways, and it's very challenging to train new doctors to do that. The time to shut down as it comes standard is very good. All right, let's talk about needles for a minute. If you look again in your manual, it'll tell you that for intraosseous, you can use the 9 mil or the 16 mil for adults. For me, I had a lot of needle bends this way, so I have gone back to great success with 9 mil, ensuring with an adult or permanent dentition. Let's call it permanent dentition instead of adult. It's just the size and the cortication of the bone that we're talking about here. I would say switch to the 1 to 200,000 or just exclusively use 1 to 200,000 and use that 9 mil. You'll have fewer bends, but expect that you're now doing an intraseptal injection. You can also get these in the gray, the 35 millimeter. I was using these before when I could not do intraosseous on every age. So we started out with the green, the white, and the gray, and now we pretty much just use the green in our practice. All right, the painless injection, the one single painless injection. The exceptions are if we have a friend and they have a really bad infection and there is not a fistula or it's not draining, you need to picture in your mind the bone is already pressurized. So the pressure sensitivity is already heightened. That's why they're percussion and palpation sensitive. That's why it hurts to bite and eat. All these things. So when we take solution and we add it to this already pressurized bone, Well, now we're making it worse. So if there is an obvious, if a child is exquisitely tender, percussion palpation sensitive, I will do a little bit of an infiltration first, try to take the edge off me going in and further pressurizing the bone. That is basically the difference. Sometimes because the speed when you step on the pedal starts very slow and it ramps up as you see in the graph below. Sometimes when it starts going faster, you'll hear the kids go like, oh, like they feel something, they notice it. To eliminate that, you just take your foot off the pedal, step on the pedal again, and then it starts slow again. And usually enough anesthetic soaked in by that point, the second go around, they don't feel it. Good little tip to live by. So when you have a clinical and radiographic assessment and you're seeing there's this infection, like you can see on tooth K here, I want everyone to picture it as a roadblock. Because even though this is a two-dimensional image of a three-dimensional situation, I am certain that there is bone surrounding that tooth. It still is compromised. The Haversian and the Volkmann canals are absolutely compromised. So when I have situations like this, I will inject in more than one place so that I make sure I'm capturing all of the bone around the roadblock. And if I have deep caries, I'll even go forward, because sometimes what happens is the space in which the solution can be filled in a situation of an infection is actually greater because the bone is not as dense. We've had some bone loss there. So where half a carpule may have been fine, if you were doing a simple restorative, now you have this infection, you have this space that the solution can run into. So we might need to give a little bit more. So just think about all these variables. And these are the common errors that I see. Usually people err on not giving enough solution. So in this situation, colleagues will text me and they say, it'll look like an x-ray just like this. I was treating K and L, and I gave a half a carpule between K and L, and I feel like the child still felt it. Well, probably a couple things. Probably you may have overblanched, so maybe you didn't really truly give half a carpule. And then probably you needed a bit more because you had more space to fill, or maybe it was a little bit bigger kid, or whatever the situation. So don't hesitate to give more in these situations of infection. And I call this the exit sign. We all have been there where we're delivering anesthesia and the solution's just running out the sinus tract. Well, obviously that's not going to do anything. So in those situations, we would also, again, want to give in two positions. And if your injecting is moving out of the sinus tract, just come out and go someplace else, because that's not going to help anybody other than make their mouth taste bad. And again, move forward if it's a big infection, get it good. So in a quadrant like this, to put this in perspective, early on, I would have thought, oh yeah, I can just do half a carpule here. Now that I look at that, and also look at the width of this alveolus in the 6-year molar area. This is a good sized kid right here. That is a very wide alveolus for a child with a partially erupted 6. They're 5 or 6 years old likely. So when I size them up like this, in this scenario, I would use a full carpule every single time to ensure I do indeed have profound anesthesia. And this situation, so we talked about where the tissue touches the periosteum, we do have anesthesia. However, I call the mucogingival junction the Great Wall of China, because I do not want to escape my stimulation past that, because I know if I did intraosseous, I indeed didn't actually anesthetize that freely movable tissue. That's not part of the deal. It's the good part of the deal because we don't have peripheral numbness. But when we need it, maybe we're flapping, maybe we have this chronic infection, this root is all tangled up in this flapping piece of tissue here, that is not going to be acceptable to do the single injection as it would be if we didn't have this scenario. And I think this is the grouch, Oscar the Grouch. I can promise you, if you don't add a little bit more sleeping medicine infiltration, this tissue is going to be very, very grouchy right there. So don't forget to do that. So again, the relationship of epinephrine, it's a beautiful thing, because when you're doing conventional anesthetic, because it decreases the diffusion, increases the length of the anesthesia due to localized vasoconstriction, holding it in that spot. It also reduces the toxicity via reducing diffusion and the rate of systemic absorption. But it's opposite of what we're trying to do for intraosseous anesthesia. So if we're injecting close to the tooth, we're treating, we don't have to use as much local anesthetic. The further we get away, the more anesthetic we need to use, because we're not just filling part of this tube called the mandible or the maxilla, we're filling more of it. And again, if we're close to the tooth, we can get away with 1 to 100,000 of the epinephrine. It's going to hold it right there where we want it. But if we're 3 teeth away, that's not going to work. It's not going to diffuse. We need to switch to the 1 to 200,000. People ask, can I use lidocaine? You absolutely can. Articaine is superior. And I can tell you, when I trained, it was forbidden. And now if you look at our reference manual, it says it's fine, it's safe, but the manufacturer readily states children under 4 years of age should not be receiving articaine. And I will tell you, I use it every day of my life on children under 4. And that is because their reference is a conventional injection. It is not an intraosseous injection. So the value, not to get too crazy chemical, but someone said, I didn't really understand that. I'm going to attend the webinar again. Break that down for me. So I'm going to break it down one more time so everyone can understand the concept of what we're doing here. And so what I got texted were all anes are metabolized in the liver. So this is an amide. Articaine is an amide, but it's also an ester. It has an ester. You can see on the molecular structure. It has this ester branch. It also has a thiophene ring right here, where lidocaine has a benzene ring. So this thiophene ring is what creates its lipid solubility. It's what makes it more fast active. It makes it diffuse through the periosteum, through soft tissues more readily. And it's really important that we understand, even though it's an ane, it is metabolized in the plasma by non-specific cholinesterases, and its hydrolyzation in the plasma renders non-active ingredients. So it's super safe. So if you have a child that has seizure disorder, you're doing intraosseous anesthesia and you're using articaine, you actually don't need to pull labs. If you have a child that's been on seizure meds, like so many of our friends in our practice for 10 years, you really shouldn't be given a conventional injection with lidocaine without at least going through their primary care provider, looking at their labs to see the impact of the long-term drugs on their liver, because it's very different. It's a strict amide and the byproducts are still active. So just a lot, I hope that answered the question. Everyone can see the ester group is not actually on the lidocaine. So hope that explains that question. Again, the safety is out there. We know that. Even our Academy reference manual readily agrees to that. We talked about this a little bit about the seizure disorder. Another great thing, which was another question that came this month, was bleeding disorders for intraosseous anesthesia. So everyone knows, if you have a child, obviously we're going to consult the hematologist, but if you have a child that has hemophilia and you are planning an inferior nerve block, let's say they're hypomineralized 6-year molars and you're planning molar substitution, you're removing these. I mean, you absolutely, there's no way around this child not getting factor. And factor is extraordinarily expensive. You consult with the hematologist, you tell them you're not doing inferior, they're not a super sick hemophiliac, you're going to be fine. Do your intraosseous with their consent, of course. Barriers to ideal needle placement that I see, I think our nitrous hood is a big one in Europe. They don't use nitrous very much. Obviously, if our friend is fussy and moving, I was working with one of our doctors the other day, and it's so calm and peaceful. And she was doing the injection, talking to the child and kind of watching the movie with them. And her angle was getting a little bit off. And I think she kind of slid into a PDL. So just be cognizant that you keep everything in line, and the circle of safety will keep it there. If you have everything locked in, you can do whatever you want. Talk to the kid, watch the movie with them, do whatever you want. I get this question weekly. How many quadrants can I do at one time? Well, that is completely and utterly weight dependent. And obviously your friend, you don't want to overextend your friend's time in the chair. But if you are an efficient provider and they weigh enough, the sky is basically the limit. And I like to give this example of this little guy because he was 5, he was a healthy kid, everything was good. He was a Frankel score, his parents were a Frankel score. It's very straightforward. So we needed to do potential pulps on a few of the primary molars and seal the 6s. And I want to bring up, I'm going to show you these x-rays for just a minute. So when I was treating children with conventional anesthesia, in this situation with such a perfect kid who weighed enough for me to do a couple quadrants, I would probably have anesthetized the upper and lower on one side and used rubber dam isolation and double rubber dam the left side for how, or yeah, which one has both? The left side of this child's mouth and knock out that side and seal the sixes with the rubber dam clamp on that, do the quadrant, do the thing. Because these parents wanted me to get all 3 quadrants done, I knew I could not give enough local anesthesia to diffuse all the way back to that 6-year molar to put that rubber dam clamp on there. So what I did is I just did the sealants real quick with an isolate. And then you don't really do it like you do conventional. You don't numb them all up and then do everything. I did 1 quadrant, the one that was by itself, and then I didn't know how well the child was going to do. So I fixed that quadrant and I did another quadrant, fixed that quadrant, did another quadrant. If it's a child I have a relationship with and I know I can do 2 quadrants and they're on the same side of the mouth, I probably would numb them both at the same time and double raincoat isolation those. But basically 3 injections, probably half-ish of a carpule, a little bit less, because we know we can't actually use an entire full carpule. When all was said and done, I had 1.5 carpules used, but it was probably like 1 1/3 used. And that's what we did. We did 50-50 nitrous, and we did these injections, we did the sealants, and then we isolated. We did 2 pulps and 3 bioflex crowns, and in and out in photos in 40 minutes. And this is an example of why I love this light, because sometimes things are going on and the lights are not as prominent on the SOAN. And you can see here, I'm doing an intraosseous injection. And right after this, the dental assistant said, "Aren't you supposed to be blue for bone?" I was like, oh, yes, I am. Thank you very much. But he was trucking along, didn't bother him. The pressure sensors weren't going up because he was so trabeculated. This is what he looked like when he finished. And he still liked me at the end, and his parents were delighted. So I'm going to show you, let's just start on this friend. So this
Then you're just going to feel just like a
I'm
little.
going to just turn this off. And she's a very anxious little lady. And instead of showing primary dentition over and over, I'm going to show you, this is a teenage girl who had these really weird mesial defects on her upper laterals, and they were starting to get caries in the base of those defects. And I'm going to go ahead and start this video.
You're too little to.
And I'm talking to her, but you can see doing the blanching step, and she's trying to talk to me while we're doing this because she's so oblivious to everything going on. Like, well, let's hold real still. If you look at the left one right now, I'm making my penetration through the periosteum, and I actually came out. I didn't like my angle. It didn't feel good. Came out again, rolled it around a little bit, and flump, I'm in there. And everything is really good. So now I'm delivering that. Now I'm doing the penetration on this side, blotting the tissue, making sure I don't have a drop on the tip of that the best I can, coming through, and you'll really see on that inner frame now, you'll see that drop right into that tissue. Everyone see it just drop then? And now I'm about 1 millimeter out, trying to hold it out so you can see. Sometimes I will start holding it with my left hand because it's just sitting there doing nothing and our friends are doing so well. What you'll see in both these videos in just a minute, this is a very anxious teenage girl, is I will start taking my mirror and looking on the palatal side with my mirror. What am I looking for? I'm looking for blanching on the palatal side. I'm looking for blanching on the palatal side because that tells me I've had diffusion of that local anesthetic that's completely crossed through, and I knew I'm going to be doing a lot of subgingival finishing, as you can see on the preoperative image with isolation. So I keep going and going. I'm going to zoom along, so maybe let's pick this one. I'm going to speed this one along to see where I'm looking with that. That one you can't see it as well. Let's see if you can see it on this one. I'm going to get to you, look with the mirror here. Oh, and I wanted to, someone asked me to show what I mean by 12 o'clock. So I never leave the 12 o'clock position now. Oh, you can see me looking at the palatal blanching on the left view now. And you're seeing that palatal blanching. It doesn't have to be profound. Any type of blanching means diffusion of your local anesthetic. But this is what we mean by the 12 o'clock view. Always staying at that 12 o'clock position with your friend in the circle of safety, getting everything done. and we're gonna go on. So we isolated, we did that, and this is immediate post-op. People ask who's the oldest friend that you've used intraosseous on. Well, there's many special friends in our practice. So 20s and 30s at workshops and colleagues, I don't know, 40s, 50s, 60s, the sky is the limit. And you'll find that it kind of gets easier, specifically with women as they get older, our bone is not as dense. So pressure indicators, you can see the little beep, it's beeping 2 beeps. It's a little bit more pressure, a little bit more pressure in there. And once it gets to the 4th indicator, it will retract until you know. It will not let you over deliver or over pressurize bone. Tips to reduce the pressure. Again, take your foot off the pedal and start pressing again so it delivers slowly. You can do that. Another tip is you can just back the needle out 0.5 millimeter. Sometimes you're up against something and you didn't realize it. And then the final thing, now that I basically use this for everyone across the board, the more talented I am at navigating my way through the labyrinth of bone, the more osseous lumen plugs I have. So everything is perfect. I'm like, why is the pressure so high? It was perfect. And it's because I've plugged a bone in my lumen. So I take it out, I hand it to my dental assistant, and the dental assistant just switches out the needle, and you could be surprised with the circle of safety, you'll go whoop, right back in the same hole you were just in, and everything is great. All right, and this kid is so cute. He's like, oh, your thing knocked my tooth out. I love this one because we normally use nitrous. The parents didn't want nitrous here. So this obviously after the blanching step, we're getting started, but this kid is 2 and he is doing intraosseous. And this is the pressure indicator for this device on the sleeper one. It's just that one. It'll blink faster if you get pressurized. And this kid's just hanging out, doing his thing. Both of these kids had past trauma. And you saw how I wiggled it out. It's real important you don't just pull straight out because sometimes it'll come out quick and you'll have a tendency to kind of poke again. Nice soccer net, and he'll just get his little teeth out and everything will be fabulous. And you'll see in a minute how tiny he is, how happy he is. Everything's funny. He kind of reaches up in a minute. He's like, what's that thing on my face? Because of the soccer net that I have to make sure we're in good shape there. Out with his teeth, not even a blink. He's oblivious to the whole thing. Now we're on our way, curette that chronic infection that he had going on there a little bit. And then he's like, what's that thing on my face right there? That feels weird. Clean that out, and then you'll see him at the end. But it really is this easy. So in a situation like this, where it's just those 2 teeth and it's such a little tiny guy, yeah, I just used a 1/2 carpule. Like, yeah, we did this. We're all so good. And that was the end of it. Yay. So sweet. Okay. People ask me 2 things. Do I have to aspirate? Absolutely not. Well, why did I see blood in my carpule? If you, and I do this frequently so that I don't have to remember to retract. If I intend to use a full carpule, I'll just let it run its course. It'll overpressurize itself and retract itself. And oftentimes when it retracts, it draws up just like a little bit of blood marrow in there, and you'll see a little bit of blood in there, and don't worry about that a bit. People say, I don't know, I see children with Medicaid, you know, can I afford to use this? Is it too much money? Absolutely not. This will make you so much more productive and make you be able to continue to see these friends. Challenges with molar and incisor hypomineralization. For those that attended the COD at the Academy meeting, molar hypomineralization, as we're supposed to say now, it's an amazing success. We know that it's a real issue trying to get profound anesthesia, about 25.9% if you just stick with infiltration with these teeth. When you're doing it with intraosseous, you raise your statistics up to nearly 90%. This study has an even greater availability of 93.5%. And this is just a thing we see all of the time. The dreaded, I say it's like the shark fins, the yellow shark fins coming out of the tissue, and you're like, no. And there's a big difference. I don't want to get into a lot of inflammatory response, pulpal response, but there's a big difference between acute pulpitis and chronic pulpitis. If you really want to dig in, read the endo literature. It's so much more in detail about this, but it's very easy to anesthetize acute pulpitis. When you have situations of molar hypomineralization, these are chronic pulpitis situations, and that's why they're so much more challenging to anesthetize, but they do respond very well to intraosseous anesthesia. It's a game changer. Again, just the angles, my practice partner Clark's angulation, this is initial blanching step. And just to show you, if you go in this way and you're like, that's just not working, it's okay to get a little bit steeper. We all know the closer we get to the crest of the bone, the less dense and organized, the further you work your way down the body of the maxilla or the mandible, the tougher that bone is. So it's okay. Just be extremely cognizant not to get so steep in your angle. You press through the bone and pass right out of the mucosa and end up doing, or into the mucosa and do another infiltration. So yes, the angle is important, but don't be afraid to come out and try again. Don't just, I committed to this angle, I'm going to push it until the needle bends. So you can come out and try again. Blanching, again, if I'm doing simple restorative, I don't care if I see contralateral blanching. If I'm doing pulpal treatment or extractions, I absolutely do. And if I don't, I will give an injection. I'm worried about a roadblock. I'm worried about an exit. I'm worried about space that I'm not recognizing, stealing my solution away. So I'm going to give another injection, and I'm going to give more to make sure that I have profound anesthesia. And this is just a little guy. This is a little tiny spot you can see on K. That's just so very easy. But I want everyone to just realize, don't get up. You know, you're gonna see, I'm doing this injection, I'm doing this injection, I'm gonna come out, wipe it off, get him a drink of water, and I'm gonna go straight to the raincoat and pick up the handpiece and get started. This should be, you know, literally a 5-minute occlusal composite, and that's it. And that child should be on their way out the door. This is mixed dentition. This is a good tip for you to learn to navigate your way through. And this is actually my learning period. So with this child, I did an infiltration, and then I was like, okay, let me just see if I can get an intraosseous. And you can see that is a bent needle. I was not successful. This child was a bigger child, so I had plenty of local anesthetic to spare. If I was able to get in intraosseously, I would have immediately isolated and gotten started with this child. This is a friend that was referred to us for zirconia crowns, and we were doing the lower arch this day. So again, anesthetize one quadrant, do the zirconia crowns. I needed to step out and check a couple recares, and then came back out, did the other side, and then delivered the other side. And this is immediate post-op. And this can be done literally under 45 minutes once you learn to use this system. This is my reminder about bone. If you were removing tooth 2, you would want to aim for the mesial of this tooth, because the bony area is so much more robust right there. And again, you don't have a permanent successor developing under this tooth. So it's okay to aim for that furcation, because the bone looks pretty nice in that furcation, where the root of 3 is very close, and it really doesn't look like there's bone between 1 and 2. So think creatively, read these x-rays for what they're worth. Big infection on tooth 19, I would absolutely do mesial and distal intraosseous injection. I absolutely would deliver a full carpule for, even if it was just that one tooth, to get rid of that one tooth. Again, crossing the mucogingival junction, this child had 2 supers. I've only seen 2 facially in my entire career, and this was one of them. You can see the hole it came out of. So in this situation, you have to do an infiltration in addition to the intraosseous. So reasons why people get robbed of anesthesia, and we're wrapping up, is space. Bigger kids need more solution, more space due to bone loss. Is there an exit? Is there a traffic jam? Is there an infection? Add more. The angle of the needle, make sure you're not off course and you're actually doing an intraligamentary, because if you're doing an intraligamentary, let's say you did an intraligamentary on T, but you're really intending to do a pulp crown on S, that's not going to work. That tooth is not going to be anesthetized. So make sure you're taking care of it. Make sure you didn't exit the bone, and in the soft tissue, do an infiltration. Do not walk away. If you give a half a carpule to a 3-year-old and you step out and get hung up with the parent in a recare for 30 minutes, you're not going to have profound anesthesia for another 30 minutes. Keep that in mind. Anesthetic choice, think about your epi concentration, and remember the difference between a true intraosseous and an intraseptal intraosseous. And this is a big kid. This is one of our colleagues in France. This is intraseptal. So doing that initial little blanching step, and then in just a minute, you'll see coming out and doing the actual intraseptal. And I'm 100% confident they actually, pretty much everyone uses 1 to 200,000 over there. This is a very long blanching step. It's like it's a pediatric dentist doing it. So they're gonna come back and come in and then pop right through that bone, 45-degree angle. And a little bit of turning, a little bit of wiggling, a little bit of jiggling. Kindness opens more doors than force, and they're in delivering the solution. So we talked about when we give 2 injections, if we're hyper pressurized already, or maybe it took us, maybe it's a crowded zirconia case. It's taking longer than you think it should. So maybe add a little bit. Or if you think you're doing it intraseptal and you want to get more than the 2 teeth on either side, you need to give another injection. What do you call it? These are my top 5. So tooth tester, magic wand, lightsaber that fights sugar bugs. Dr. Allison Eggleston in North Carolina, she calls it Joanne the Soan, and Dr. Tony Sato calls it Soana, kind of like the Toto song Rosanna, which I think is just great. We already talked about when we infiltrate extra, and no, this is not the same thing, and it's an emergency intraosseous access. That's a huge needle, and this is different. Very different, very cancellous bones. So even though this is our last resort in emergency medicine, it's our first resort for compassionate delivery of local anesthesia for children. Workflow, less gloves. I calculated $5,000 per doctor in our practice. That's $35,000 a year. That's a lot of money. Not to mention the impact to the environment. I don't have grandchildren, and they better not be coming anytime soon. But someday I want them to live in a beautiful planet with a little bit of great harmony and not kill the environment. And even if we use biodegradable gloves, that just means we enter gases into the environment faster. Efficiency is everything for happy children, and happy children make us happy. So all these impacts to the change in our workflow. Cost of integration, it depends on, we talked about this briefly, depends on how much operative you do in your practice and how you optimize lucky day opportunities. That's the way we roll. We try to do the most for every child that comes in the door. So for us, literally, it's a week per device, definitely. Do I feel like ultimately it will replace traditional? Absolutely, 100%. One of our colleagues, Nate in France, he said in March, I met him in March, he said, Larry, I met him in Houston. He's like, I don't get what's been going on in the US. If my dental high-tech device didn't work, I would just cancel all my patients and go home. And that's the way he feels about it. And that's the way many of our colleagues feel about it who've used it a long time. I'm almost to that point. I've been a business owner for a very long time, so I'm not sure I'd cancel a full day of patients, but I get what he's saying. So what I've learned, prepare the parents. This seems like eternity to have a needle inside their child. So you need to tell them, we're going to stay here for a long time. And that's to make it not hurt. I mean, privately, never use the H word in front of children. Make sure you retract your plunger before your dental assistant removes the container. That device is highly sensitive and we don't want them to bend it. And you have to remove the needle to release the carpule. It's very important. Otherwise, they're trying to pick it out with cotton pliers and do all sorts of weird things that doesn't work. Remember, the better you get, the more osseous lumen plugs you're going to have. So just like something's happening, it's pressurizing, it won't go, take it out, switch the needle, you're going to be great. And then finally, I know that one of my dear friends and the best anesthesiologist that she's just an honor to work with, Dr. Rachel D'Souza, is on this call. Some people say, well, who cares, the kid's asleep, it's not going to hurt them. But we all know about emergence delirium and the impact, especially for those with special needs. They're already itching their nose from the narcotics. And then we have this big fat numb lip we've given them, which is irritating them. And unfortunately, we kind of like pull the throat pack and peace out. And the nurses and the anesthesiologists have to deal with this. So I think a lot of value needs to be put into considering this, using dental high-tech in the operating room to prevent peripheral numbness and increasing the frustration of emergence delirium. Again, if you haven't scanned me yet to get on my contacts, that's my beautiful family. And then here are these great guys one more time. And I'm going to close out almost on the dot. So just like that, I am so excited to hear your questions and drink some water.
Exactly on the dot. Look at you. Thanks, Dr. Johnson. Appreciate it. We do have a few questions, so we'll go through these. Again, if you have more, just keep adding them. We'll stay here as long as you guys want to answer all your questions. First one is Articaine versus Xylocaine, which to use?
So xylocaine is lidocaine, 2% 1 to 100,000. Absolutely articaine, which septicaine. So that's articaine, 4% articaine is what you want to use. If you don't want to order two things or train your dental assistants, be like, we're using 1 to 100,000 on the little bitties, we're using 1 to 200,000 on the teenagers, you could just order 1 to 200,000. That's perfectly acceptable. So absolutely go 4% articaine.
Awesome. Next question, is the needle of specific gauge and size for intraosseous injection, or is it the angulation / bevel on the needle tip that makes this intraosseous?
Ooh, that's a good question. I love it. So the 9 and the 16, the two that I would say you would have in your practice are both 30 gauge. There's also 20 gauge and 27 gauge in the 16 and the 35. So what makes it successful is all of this that you just said. So when you're doing intraosseous, you're absolutely using 30 gauge. It's going to navigate through that labyrinth and be that kindness opens more doors than force and manipulate its way through that periosteum much, much better, much, much better. If you are on your learning curve and you're still doing inferior alveolar nerve blocks, you need to order the 27 gauge 35 mil. 35 mil only comes in 27. Now, I don't want to get into a big controversial thing. I'm not one of these people that feel you have to use a 27 for inferior alveolar, but that's the way it comes with this needle. And this needle is superior compared to anything I've ever used. So moral of the story is absolutely 30 gauge. The bevel is absolutely the key to the painless injection. I think the bevel, especially when you're sliding through that soft tissue initial so they can't feel it. But I think the bevel also helps with the navigation through the periosteum, all those things. Such a smart question.
Yep, absolutely. How long does the anesthesia take to wear off? Any post-operative instructions?
Okay, so if you're using 1 to 200,000, and we all know our metabolism is increased. We're clearing this, we're metabolizing this in our plasma. So if a child is a little anxious, even if they don't show it, like I will say a teenage boy will probably burn through anesthetic greater than anybody. They come in a little anxious, but they're all tough and they don't show it. So if you're using 1 to 100,000 and you're using a full carpule, you should be good for 45 minutes. If you're using 1 to 200,000, you should be good for 30 minutes. And I will fully disclose that some of the literature will take that, both of those up for 15 minutes. But I'm one of these people, I'm not just talking about anesthesia. I'm not talking about those last 15 minutes because you're doing a restorative, it's going to be okay. I'm talking profound. At any point in that 30 minutes or that 45 minutes, I would pick up a forceps and remove a tooth and it would be okay.
Awesome, thank you. Next question is, how long does the, I'm sorry, we already did that one. Sorry. Earlier you mentioned 1 carp of septo per 40-pound patient. Just wanted to clarify this as it is less than 7 milligrams per kilogram recommendation.
Yeah, and that's the max dose. So for me, it's just a quick and dirty. You're never going to overdose a kid if you just go with the quick and dirty. And so if you want to take out your calculator and calculate to the pound, you can. But for me, that's just, it's my easy thing. So if they weigh 60 pounds, I know we are good to go with 1.5 carpules. If they're 80, it's 2. It's just quick. And if I'm pushing the limit, let's say they drove a long way or whatever, and I'm maxing it out, I will calculate the 7 mg per kg.
Great. This is a good one. How does the anesthesia wait time with these devices compare with traditional anesthesia wait time?
Like I'm assuming this means until they're numb.
I
wait
think
time,
so.
I think
Yeah.
so. It's 0. You pull the needle out, you isolate the tooth, or you pull the needle out and you reflect the soft tissue and extract the tooth. It is just like that. I mean, you saw the videos of the 2-year-old. I pulled the needle out. She put an elevator in my hand. I mean, a periosteal elevator in my hand. I released the soft tissue and put a forceps on the tube. It's just like
Right.
that, 0 weight.
Yep, absolutely immediate. How do you set it to make a sound for every quarter carpule used? It is hard to read the amount of local during use.
Yes, and so in the so first of all, that's only the SOAN. You
Right.
cannot set that in the sleeper one. So you need to do, and then I would say read the manual, because it's kind of tricky. The settings, you push a pedal, hold the button, do some things. And if you have any problems, I'd reach out to Chris or Jordan and they can FaceTime you and walk you through it.
Yeah, I was going to say too, we can, this is a good time to stress the importance of that onboarding and training process available too. So, during that initial onboarding and training, we go through all the settings and help you set up the device and go over all that with you. So if you have done that, and maybe have forgotten, we can absolutely do it again. If you haven't and are a newer user or even an older user, just reach out to us and we're happy to get on and do that again for you guys. So, let's see, next question. How do we line up the D on the needle to also be able to see the lights blinking on the device? I know you're
Okay.
gonna like this one. Go ahead.
I love this because this is a game changer. So what you do before you put it in the kid's mouth, you have to know which way it's going to face. And if it's not facing the way you want it to face, don't tighten the needle tighter, because that can be damaging to your device. And also, we've had one needle stick because of taking off an off product. We ran out of Epitech and we had an off product needle on there. So unscrew the needle versus screw it tighter so that the D is facing the proper way. So that's the way you can do that. The other thing is, if you don't do that preemptively, the dental assistants are trained. You only need that D facing that certain way during the blanching step. So that's just a few seconds of the procedure. So if I'm not looking at it, the dental assistant will say it's blinking and they know what's going on. And then when I come out, I turn the lights to face me so that I can see them during the intraosseous portion.
Awesome, great. Real quick, if you can go back one slide to show your contact info, hit a question to
Absolutely.
see your contact info again.
Absolutely.
Guess we can
You
leave
can
that up
scan
instead
that.
of me and Jordan's ugly mugs. Next question is, I have tried the SOAN several times, but majority of the time I got soft tissue numbness. How can I avoid this?
Okay, so I've had that happen before too. So a couple things happen. 99.9999% of the time on the mandible, because we're so compassionate, we over blanch. And so we're actually getting a little bit of soft tissue infiltration into the mental nerve area. So I've done that too. And in fact, at a workshop, one of our colleagues wanted me to do her, and she wanted me to do it right where the mental foramen is. And she had just a little bit of that. And by the time we got done talking, 30 minutes later, it was gone. So you might get a pinch of that peripheral numbness with either your blanching step, or maybe you infiltrated down to that mental foramen just a little bit on the mandible. But it's not going to last. They're not going to go home and chew their lip and do all this, because it's not going to last for an hour. So it's a different type of peripheral numbness. On the maxilla, the situation, one time I did that because I knew exactly what I did, because I steepened my angle. It was an older child that was struggling getting in, and I steepened my angle, and then I started seeing blanching in the vestibule. So I actually exited the alveolus, and I was back to doing infiltration due to the angle. And the child had like a really scalloped alveolus. And you'll get where you look at the alveolus and you're like, oh, that really curves back in. I have to be careful. And there's several scenarios. But even if you do, it's not the same type of peripheral numbness as depositing a carpule of an infiltration or having an actual nerve block.
Great, thank you. Another great question. If you are planning on 2 injections in different spots, let's say A and B and S and T, should you do both blanch steps first, then the IO step, or swap the needle because of dulling?
Man, I should automatically, thank you for asking this really smart question. So no,
Mhm.
if you're in the quadrant, so S&T, so I'm gonna, let's say I'm starting, let's say S is abscessed, and I'm starting between S and T. I do the blanch step, I drop in, I let it go, but there's an infection on S. I wanna make sure we have profound anesthesia. Even though it might not be profound enough to take that tooth out because it's abscess, I promise you it's enough anesthesia. You don't need to do the blanch step again. Just drop into intraosseous. That's a really super smart question. As far as needle swapping, well, let's reflect here. Let's say it's a 21-year-old that just finished this year of college and they came in to see me and they've been sucking on, Gatorade since they've been in college, and I'm doing MODs in the whole upper right quadrant. And it took me a little bit to get in. I had to do a bit of twisting. I had to do a little bit of this and I had to do a little bit of that. And now I need to come forward because that was an intraseptal intraosseous because I used a 9 mil on a big boy. Oh yeah, I'm switching out that needle because I know I dulled it. I had a very hard time. And that's a good rule of thumb. You'll know when it's sputter and you just drop in, you're like, yeah, I'm fine. And then when you struggle, yeah, even if you get in, you better change the needle before you drive on. Good
Yep,
questions.
absolutely. That was the last question as of right now, so we'll hang out for a few minutes. If anybody has any other questions, just chime on in, but we'll hang out for a few minutes before we end this for the night.
Someone
Sure.
actually texted me a question.
Oh, great.
And
There you go.
so let me read this question out loud. So the question is, how does intraosseous local anesthesia affect your material choice? And I think I know what you mean. I think I know what you're getting at. So if you're asking, let's say I'm doing a zirconia crown versus a stainless steel crown, it's truly indifferent. Truly in that aspect is indifferent. But let's say I have a hypomineralized molar, and a lot of us, when we were struggling with anesthesia, were moving toward glass ionomers because of this chemical bond versus the mechanical bond with the composite. But we know composite is more long lasting and more polishable. And it also withstands, it has more strength, more compressive strength. So if the hypomineralization, extended onto the ridges of the cusp or something, the composite would be actually a better material. So let me read the question again. So if I think I think what you're saying is, has it changed my choices? And I would say yes. At this point, I get profound anesthesia with hypomineralized molars. So I would go through complete affected tissue removal and do a composite versus just this squishy stuff, do a chemical bond with a glass ionomer that I know is more of a provisional restoration. And then I'd cement an orthodontic band on top of it. I hope that answers. Text me back. Text me back if that's not what you're talking about. Okay.
That's definitely the first time we've had that question, huh?
Yeah, I think we touched on it briefly and someone didn't understand it exactly, so they just wanted me to say it one more time.
Gotcha. Okay. All right. Well, give it a few minutes, everybody. Again, Jordan, did you have something you wanted to add to something?
I was going to ask, I had this question come up the other day. When, let's say we inject between A and B, and then, like you said, on a 21-year-old, but then to come forward, would you still do the blanching step for the next injection?
A bigger person, no, I'm sure I would capture, I would give more local anesthesia. If I was doing like this kid who just finished college this year, it was 2, 3, 4, 5. And so I did a carpule between 2 and 3 because 3 was the big lesion. And I did like a half a carpule, the mesial, and then a half between 4 and 5. And then he was great. But he was a really big kid. But I did not blanch after the first one. No. These are good questions.
Great. Just to reiterate again, my contact info and Jordan's contact info are in the chat. We'll leave Dr. Johnson's up for everybody, but our email addresses, contact info is in the chat. Reach out to us with questions too, especially for scheduling the onboarding, training, one-on-one training, anything like that. I'm happy to help out as much as you need. So give it a few more minutes. Everybody can hang on just a few more minutes, see if there's any last minute questions. Then we'll let you let everybody get on with their night, but want to make sure everybody has an opportunity.
Oh, the car. So
There we go. Yep.
Yeah. So it just goes in the autoclave. It's just that simple. You just unscrew it and put it in a sterilization envelope and it goes in the autoclave.
Yeah, the plastic containers that house the anesthetic harpule are autoclavable, just like you would autoclave anything else. And then the unit itself, both units, you would just wipe with a cavi wipe in between every patient.
I had a question emailed to me here. Can you talk a little bit more about the technique for dropping into the bone? Bending a lot of needles and can be a little frustrating.
I know it can
Great
be
question.
frustrating. And I've bent a lot of needles too. So I'm not even gonna lie. There is a learning curve to this. So my key things are I surrendered from the 16 millimeter. And I just choose to do intraseptal if it's a bigger kid. And that is the first thing. That had very poor success for me. The second thing is twisting, and then just trying not to, early on, I was anxious, very anxious. And so I was applying force with less focus on keeping my force in the long axis with the needle. So if the force is not in the long axis with the needle, you'll bend. And the best way to stay in the long axis of the needle is really use the circle of safety. Don't be suspended like our hygienists. You're going to struggle. If you have a circle of safety with octopus fingers hanging on to everything locked in, and you're just making tiny little adjustments, making your way through that bone with very gentle kindness, it just makes it easier. And then one day you're going to be like, I get it now. You're going to know exactly how much force is too much force, and it's going to bend that needle, and then you're going to stop. So the other thing is, don't be bashful. Don't commit to that angle. Just come out, gently try another. If that's not it, come out, try another. If you've done that 3 times, you probably should switch your needle. That's okay. And then go back in. You're going to have success. And don't feel bad. Yeah, I was the bent needle queen for quite a bit, especially graduating to the permanent dentition.
Part of the learning process for sure, right? Yeah. We have a great question about the foot pedals. So both units.
Can I answer that one? Because I only have one answer.
Go ahead.
It's some magical juju. It doesn't have a battery. It's a Jedi foot pedal. It uses the force to stay charged. I do not know. But anyway, you got anything better than I do other than Jedi force?
That was going to be my answer. It's just magic.
Okay.
But
Magic.
no, in all seriousness, it's a radio frequency that syncs with the unit itself. So every single time that pedal is pressed, you'll notice like a clicking sound. That clicking sound is sending that radio signal to and from the device, which is keeping that unit charged and synced with the foot pedal. That there's no maintenance or charging or swapping out batteries or anything on the foot pedal for both devices.
Yes, it can. I was just about to say,
Yes, yeah.
but ask me how I learned the hard way. They are
Yeah.
unit specific. So
Yeah.
don't let someone swap it up. You'll be pushing all day and nothing's going to happen.
Just a slight quick label or something like that, number system for for multiple units so that they stay with their respected foot pedal. Good. Let's see. No other questions than that. Give it a minute and then let everybody go. All right. We will call it here, everybody. Little quiet, so we'll call it, but appreciate everybody hanging out again for joining us on this evening. Dr. Johnson, thanks again as always. Please, everybody, please reach out to all three of us if you have questions. That's what we're here for. Happy to help out in any way that we can. So everybody have a great night. You'll receive your emails here shortly from Chandler with the survey and CE information. So any issues with that, reach out to us as well. And we will see everybody on the next one. Have a great evening, everybody.
All right. Bye, friends. Good night.
Thanks, everybody.
Thank
Bye-bye.
you.